Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. This is our first session in the recall workshop. I'm welcoming the new members and I hope you have revised or at least reviewed the recall files so that if you have any question we can discuss it together today, inshallah. Okay, I was thinking to start with gynecology, not the obstetrics. What do you think? Okay, no problem, as you like. Oh, okay. So we have something new regarding obstetrics because the NICE guideline has been updated this year. Okay, so forget anything about the management according to the CTG before, and please make sure that you don't build your concepts according to the answers in the recall file because there are many wrong answers. Okay, so try now to remove everything and start all over. We are going to revise together the new CTG categorization and the management. Okay, everything in the CTG categorization can be asked about in part 1. Okay, so before we have some features in the CTG that we are going to depend on to say that this baby is in extreme danger or this baby is in current danger, but we can do something to help him. Or let's say manage the acidosis or hypoxia that the baby is having. Now we have the same features, but we're not going to call them normal, suspicious, pathological. We are going to give them color code. We now have white, yellow, and red. Okay, white, amber, and red. So if we have something or some features like contractions fewer than 5 contractions in 10 minutes, which is normal, we're going to consider it as normal. So this is white. So it's easier now to talk to your team in the labor ward about the CTG results. You are going to say this CTG is amber, this CTG is red. So the team now is having an idea without conflicts between terms. Okay, so it's just the same like before, but the only difference is the definitions or the terms that we are going to give the categorization of the features. Okay, they can ask you a question, theoretical, very theoretical one, not in a scenario like what is the normal fetal heart rate? 110 to 160 beats per minute. Yes, this is the baseline. Okay, this is your normal baseline. Any increase in the baseline or decrease should be considered abnormal. Okay, so if I'm going to have increase in the baseline 20 beats per minute or more, okay, or I'm going to have 100 to 109 beats a minute, this is amber. If I'm getting below this cutoff, below 100, this is bradycardia. Above 160 is tachycardia. Okay, fetal bradycardia and fetal tachycardia. This is exam question. They can also ask you about normal variability. Okay, guys, not a scenario, not a CTG paper or anything. Just asking you a very basic theoretical question. Okay, now we have those 3 categories. Okay, we have features We have contractions, baseline, variability, deceleration, and so on. So if I'm having a mixed features between them, they say if you have no amber or red features, all features are white, so this is a normal CTG. Okay? If you have one amber feature, this is suspicious CTG. If you have one red feature or more than two or more amber features, this is pathological CTG. Okay? This can be a question also. They can bring you a CTG and make you assess it. And if you find one amber feature, which was borderline before, this would be suspicious CTG. Okay? Amber feature. Amber feature. Amber feature. One amber feature is suspicious CTG. Okay, how we are going to decide about the management? The new recommendation trend is to be conservative as much as you can. Okay, conservative, conservative, conservative. So let's start with the normal CTG. If the CTG is normal, so you are going to stop it and continue your assessment with intermittent auscultation. Okay, unless you started the CTG because you have something abnormal with intermittent auscultation. In this case, you are going to continue on the CTG. Okay, and you are going to continue the full risk assessment every hour. Okay, if the CTG trace is categorized as suspicious, okay, we suspicious means one amber feature. Okay, no red features, one amber features. Okay, and there is no concerning risk factors like the mommy is not having a medical disease or chronic condition, or there is no complications like bleeding or anything. What should we do? Conservative. Okay, so I'm going to try conservative measures, and I'm going to tell you what are the conservative measures. Those conservative measures should return the CTG to the normal one, or they should no. When the features are amber, one amber feature, we are going to call it suspicious CTG. Okay? When two amber features or more, we are going to call it pathological CTG. And anyway, in the management, you are going not to find a big difference between them, except for some very specific cases, and I don't think they are going to bring it for part one. Because mainly now, if you are having a suspicious or pathological CTG, you are going to try the conservative measures first, okay? And consider fetal scalp stimulation. If this is not going to be or have successful return of the fetal activity to normal, fetal heart rate to normal, then you are going to exhibit delivery, which means you have now tried to change the maternal position. You're going to encourage her to mobilize or do whatever the position she feels okay with. Avoid being spine is most important, okay? If she's hypotensive, you are going to offer her IV fluids. If not, please do not offer IV fluids if the mother is not hypotensive. To treat the fetal heart rate abnormalities, this is not recommended. Okay? Just like the oxygen. Just like the oxygen. This is new recommendation. Oxygen before was one of the conservative measures that we should take if we are having a suspicious or pathological CTG. Now they are saying it may harm the baby. However, if the maternal body needs oxygen, she is hypoxic, okay, now she needs oxygen, she can take it. But you are not going to offer her oxygen without being hypoxic. Okay, so it's much easier now, I think so. For the hypotension, for example, you may have a woman who is having epidural, and you know that epidural can cause hypotension. Being hypotensive can affect my baby because it will affect the perfusion of the blood to my baby. So I'm going to see some changes in the CTG. So I'm going to give this woman IV fluids. When I give her IV fluids, I'm going to start to see some good changes in the CTG. It's getting back to normal. So this is good. If this does not happen, if I'm trying the conservative measures, but the CTG is not getting back, what should I do? I should exhibit delivery. Exhibit delivery means I should deliver this baby right now. So according to the situation, the whole situation, I'm going to decide if this woman can have instrumental delivery or no. The prerequisites for instrumental delivery is not there, so I'm going to open her up. And when I'm open her up, I'm not going for cat 1 cesarean section. This is cat 2. Okay, guys, cat 1 cesarean section is for very urgent cases, like placental abruption, acute bradycardia, acute acidosis, suspected uterine rupture, severe hemorrhage, cord prolapse. Those are acute events. Okay, so in those acute events, also we are going to try the conservative measures until we prepare the theater. Okay, we are going to prepare for urgent birth and ask for pediatric and neonatal support. Okay, we are going to prepare all this and try to open her up as soon as possible. This bradycardia, how long should this bradycardia be considered as acute? If it persists for 9 minutes, or you are having a single prolonged deceleration for 3 minutes or more. Okay, so I'm having now, let's take a scenario. I'm having now a CTG, okay, with single prolonged deceleration for 3 minutes or more. I'm going to do what? I'm going to do urgent reassessment, undertake conservative measures, make preparations for urgent birth, okay, including requests for pediatric or neonatal support and so on. When should I open this woman cat 1 CS or do immediate instrumental delivery? This is what exhibit birth means. When the acute bradycardia persists for 9 minutes, this means open her now. Okay, so only pathological or suspicious CTG without any other risk factors does not mean cat 1 cesarean section. If you need to open her by cesarean section, you are going to go for cat 2 cesarean section. Okay, can anybody tell me the difference between cat 1 and cat 2? the timing. Yes, excellent. Both are urgent, okay? However, when you have a cat 2 cesarean section, it means you need urgent delivery because of something wrong with the mother or the baby, but not immediate. Not immediate. The immediate threat is cat 1. When you only have maternal or fetal compromise, but not immediate life-threatening, this is cat 2. Okay? Now the timing. You haven't told me the timing. There's a little debate about cat 2, but cat 1, it should be within 30 minutes at most. Okay, cat 2, we are talking about 60 to 75 minutes from making the decision. Cat 3 means there is no compromise, but we need early delivery. Like what? Like what? Like in case of twins, for example, okay? And they are monochorionic twins, so they are going to be delivered by CS, and monochorionic twins are going to be delivered by 35 weeks. So this is cat 3. Cat 4 is totally elective CS. This is a planned CS that suits the mother and the team or the family members and so on. This is elective. Elective CS is cat 4. Scheduled CS is cat 3. Urgent is cat 2. Immediate is cat 1. Okay? Great. So what about fetal scalp stimulation? Because this was a very common answer for many scenarios in the recalls. The NICE guideline now is saying that they are unable to make a recommendation about fetal blood sampling. So we are not going to use fetal blood sampling unless new recommendation came out with appropriate evidence. But we can do fetal scalp stimulation. Okay, we can consider digital fetal scalp stimulation if the CTG trace is suspicious. Okay, because this would lead to acceleration in the fetal heart rate. If we have absence of acceleration in response to fetal scalp stimulation, that means that I should exhibit delivery. Okay. We have the kinds of decelerations. I know you know them. We are going to review them very quickly. We have early deceleration, which is very benign. It's physiological. They can ask you about the cause of those type of deceleration because of the effect of uterine contractions on the baby's head. Okay, the intracranial pressure, fetal head, yes, fetal head compression. The intracranial pressure is going to rise up, so it will cause transient hypoxia. So we're going to have those deceleration. They start with the contraction and end with the contraction. So that means that they are early deceleration. Those are physiological deceleration. Okay, variable deceleration means a rapid fall in the baseline of the fetal heart, but in variable phases or in variable places that has nothing to do with the contraction. Has nothing to do. Mainly, it's caused by umbilical cord compression. Okay, and they are not only variable in places, they are variable in timing. Okay, some of them, they are going to be long, some of them are going to be short, and so on. Okay, late deceleration is the one we fear for. Because late deceleration equals red feature. So only one late deceleration means you are having a pathological CTG. Okay, so this is a late deceleration. How I know? It started with the peak of the contraction. The peak of the contraction. Where is my pen? Which means when I'm having a contraction now, okay, this is the peak of the contraction. I'm going to get up. Yes. Here we go. Started here. Okay, so that means that this is not head compression. This is not umbilical cord compression. There's something has to do with the blood vessels in the placenta. When the muscles contracts, the blood vessels are occluded. So the fetal heart starts to decline. Okay? And when the contraction resolves, the fetal heart starts to get up again. This is late deceleration. That means that we are having a reduced uteroplacental blood flow. Okay? This is a real fetal hypoxia. What are the management of such deceleration? Again, conservative measures. Okay, correct any underlying cause. Like what? Like hyperstimulation. Like hypotension, maternal hypotension. Like preeclampsia, hypertension. Okay, if it went well and the baby regained the normal heartbeat, then fine. We're going to continue our observation. If not, we're going to exhibit delivery. This is how prolonged deceleration looks like. See, it started, let's say here, until it gained here. So let's count. Big squares mean 1 minute. Okay, every big square is 1 minute. And the rate of the CTG is 1 centimeter per minute. Okay, so we have here 1, 2, 3, 4 minutes. This baby is having prolonged deceleration. Okay, and any prolonged deceleration more than 3 minutes is red. Yes. Before we were saying abnormal. Reassuring, non-reassuring, and abnormal. Now, no, we are having new classifications. So the one that lasts between 2 to 3 minutes is amber. The one longer than 3 minutes is red. Okay. This is the sinusoidal CTG pattern, and it's very concerning. That means that we are having a severe problem, because here we are having absent variability. There is no variability within the 1B. Variability is to have variable heart rates in 1 minute. In 1 minute. See here, it's very smooth. Very smooth. Okay, in 1 minute, like here, for example, we are not seeing any kind of variability. It's wave-like. Okay, no beat-to-beat variability. This means severe fetal hypoxia, severe fetal anemia, or fetal maternal hemorrhage. Okay, when you see a TTG like this, CAT1CS. If the woman is not the head on the perineum, if you are having something like head on perineum, okay, I'm going to deliver her vaginally. But anything less than this, and you cannot do an immediate instrumental delivery, CAT1CS. Okay, we are having now the first question. All the questions today are going to be recall questions, okay? We have this multipara woman with previous normal delivery with labor pain and membrane ruptured. Okay, we try to line the important words, because maybe in the choices you are going to have ROM, rupture of membranes. What would be the next step, and so on. So we are having the membrane ruptured. We have thick meconium. Thick meconium means an indication that the fluid around the baby, the amniotic fluid, is very, very low. So when he pooped, the meconium is not diluted with the amniotic fluid. It's now thick. And she's 5 centimeters dilated. She's not fully. Okay, she's not fully. That means that I cannot do an instrumental delivery. So what is the plan? Okay, let's see the CTG. Let's see the CTG. This is early deceleration, early deceleration, early mirror image, mirror image. This is early also. They are all early decelerations, I think. So this is a normal CTG. Okay, I can see good variability. Okay, I can see good baseline, because you can say that the baseline is around 120, right? So I think all good. You agree? Okay, so now what should we do? We should continue the CTG and reassess again. Okay. If I'm having, I should add something here. If those deceleration were variable or late, what would be the answer? Conservative measures. Yes, thank you. Remind me to add something here. Okay. This one. Are having normal vital signs, and the fundal height is like the gestational age, and we have normal CTG tracing, but this woman is having painless vaginal bleeding, mild painless vaginal bleeding. What would be the best next step? First of all, we need to know the source of bleeding, right? The source of bleeding. So I'm going to perform a sterile vaginal examination. Then, if I still don't know where is the source of the bleeding, I can perform the ultrasound. Okay? And if it's heavy vaginal bleeding, I would order FBC, and cross-matching. Okay, this one. We have some keywords here. The keywords are, this woman is in labor and she's exhausted. Exhausted means that she's not going to help you anymore with pushing or anything. She needs delivery now. So I'm thinking now of exhibiting delivery. Exhibiting delivery means either I'm going to try instrumental delivery or resort to cesarean section. Let's see. We're having prolonged late deceleration. Okay. The baseline is 170, so this baby is tachycardic. Okay. None of the presenting part is palpable per abdomen. So I'm having engaged head. The cervix is fully dilated. Excellent. The vertex is at +1 station. Great. And I'm having occipital posterior. Okay, until here, can I do instrumental delivery or not? The prerequisites are there or not? I'm having engaged head, more than 2/5 per abdomen, right? I'm having fully dilated cervix, okay, and ruptured membrane, right? So I'm looking now for, am I going to do a rotational delivery or normal instrumental delivery or non-rotational? According to the occiput. If the occiput is anterior, so this baby does not need any rotation. If the occiput is posterior, so I need to rotate this baby. And rotational delivery always happen in theater because there is high risk of failure and I might need to resort to the CS. So I need to be in theater, not in the labor ward. Okay, guys? Those are the indications for instrumental delivery. As you can see, one of the most important indications is maternal fatigue or exhaustion. Okay, and they are going to tell you, don't worry about it. This is one, by the way, of one of the hardest scenarios that came for part one. One of the hardest. Okay, or if we have inadequate progress. Okay, so how we know that we have inadequate progress? When we have total timing in stage, second stage, 2 hours for nulliparous, 1 hour for multiparous. Total time spent from the time she had a fully dilated cervix. This is stage 2, or the second stage. Fully dilated cervix, and she had been fully for 2 hours. Okay? This is inadequate progress. For multiparous, 1 hour. If she's having epidural, add 1 hour. So for nulliparous means 3 hours in total. For multiparous, 2 hours. Basically, again, if I'm having 2 hours spent in the second stage, okay, for nulliparous, 1 hour for multiparous. Active or passive? Okay. Passive means that she's not pushing. She's not having the urge to push. She's fully, but she does not have the urge to push. Active means she started feeling the urge to push. Okay? But in both of them, the cervix is fully dilated. This is the second stage. Okay, this one. We have membranes ruptured. Cervix is not fully. Okay. Vertex at 0 station. 0 station means it's not really the cup of tea for instrumental delivery. Okay, we need at least +1. This is mid-cavity forceps. Okay, the CTG shows 1 variable deceleration, 1 acceleration, the baseline is 120, and adequate variability. And the contractions is 3 every 10 minutes. Can you see anything wrong here? The thick meconium only, it's not a problem. Okay, the CTG is okay. Thick meconium is not an indication for CL. Okay, so yes, we are going to continue the fetal monitoring. Okay, this is one of the hardest also. Okay, and I'm not still sure. The late deceleration was for how many minutes? They say in the recall that it is for 20 minutes. Okay, anyway, let's see. Don't think much, be systematic. I'm having a cervix which is 3 centimeters dilated with intact membranes. Can by any chance I can do instrumental delivery here? No, of course not. Okay, the labor is being continuously monitored using CTG, and the parameters are, we are having bradycardia, no acceleration, which is okay, but when it's present, it means that this baby is not likely to have acidosis, but its absence means nothing. Okay, we have low variability. Okay, so we are having low variability, we are having bradycardia. Okay, so those are one red feature and one amber feature or red feature. One red features means this is a pathological CTG. Okay, I'm going to try conservative measures. Okay, or if I failed, then I'm going for cat 2 cesarean section. Right? You agree or not? Why not B? Because oxygen therapy is not recommended anymore. Okay? If we change a very little detail in this question, okay, if I told you that there is one late deceleration for 9 minutes, one of the late deceleration continued for 9 minutes, what would be your answer? Cat 1. Yes, this is acute bradycardia. Okay, here we're having a woman induced with dinoprostone. Okay, and 20 minutes later, the pessary is removed. I don't know why. Anyway, regarding the following CTG, what is the most appropriate management? Okay, let's count. Because they said dinoprostone, so I'm expecting to see what hyperstimulation. Okay, let's see. if I'm having hyperstimulation or not. I need 10 minutes. I need 10 minutes. So from here to here, those are 10 minutes. Oh, this picture is really bad, but this is in the recall files. Okay, so I guess this is 1 minute, 2 minutes. We need help. 3 minutes, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. I'm not sure I'm counting right. 14. No. If you can see, but I can see the hard lines. Those from here to here. This is 10 minutes for sure. So at least I'm sure that between here and here they are 10 minutes. Okay. So honestly, it depends. It depends. If we are having more than 5 contractions per 10 minutes, okay, this is hyperstimulation. So I need to remove the pessary or stop the oxytocin, if any, okay? If it's still having hyperstimulation, I'm going to give her terbutaline. Okay, guys? I'm going to give her terbutaline. Antitocolysis or tocolytic. Okay, this is the next step. But if it's okay, there is no hyperstimulation, I'm going to see the baby. If the baby is doing okay, the CTG is normal, I'm going to reassure and observe. If the CTG is still pathological, even I tried the conservative measures like removal of the pessary, and the TTG is still pathological, I'm going for CAT2CS. Honestly, here I cannot say for sure if there is reduced variability or not. But we can say that this is a good variability within 1 minute. This one here, there is a good variability. And yeah, here also, this is good variability in 1 minute. Okay? In 1 minute means this 1 minute, the big square, but I cannot see the small from big squares here, honestly. But I depended on this one, for example, or here. This is a good, okay, this is a okay variability, at least 5. At least 5. It means simply, if you have the baseline at 120, okay? In the next 1 minute, I should see variable increase and decrease in the heart rate. In the 1 minute, in the next 1 minute, from here to here. Let me make it more obvious. From here to here. Okay, if I suppose that this is 1 minute, no, it should be a little bigger. I cannot see clearly, honestly, I cannot see clearly. Okay, if I suppose that this is 1 minute. Okay, can you see variability in the heart rate? Okay, 5 more, 5 less, at least, up to 25 more or less, 5 to 25. Okay, so the baby here, for example, he was at the beginning of this minute, he was 120, then 124, then 125, then again 122, 120, then again 125, and so on, and until this minute is over. This is normal, this is good. But if he is having 120, then 140, then again 125, then again 122, and so on. This variability is abnormal because it's more than 25, right? So I'm having a limit from 5 to 25 beats per minute. You got it now? So yeah, if I cannot count for sure, honestly. So if I say that I have counted this before, and I think I got that from here to here are 10 minutes. I remember so. So those are 1, 2, 3, 4, 5. Okay, 5 contractions. Not more 5 contractions. Okay, more than 5 contractions, this is the hyperstimulation. Okay, guys? If it was from here to here, this is 10 minutes. If only I can see those numbers. Anyway. Okay, let's try from here to here. But then no, this is too little for 10 minutes. If they are more than 5, the correct answer would be gifted Ritalin. Why? Because I already removed the pessary. So this is hyperstimulation that needs treatment. Okay? Okay, in this case, I'm having a baseline heart rate of 150. Is that okay or not? Yes, okay, okay. Variability is 4 for the last 30 minutes. This is amber, right? Okay, no acceleration, no problem. We have variable deceleration. Okay, so I'm talking about amber or red CTG. I need to know. I need to know. Because they are asking me whether this is a suspicious or pathological CTG. Okay, in the recall files, and we used to answer it D. But this is not correct. This is not correct. Okay, let's see again. Again, she's priming. She's now 6 centimeters. Okay, the CTG was normal before. And now the registrar is confirming that the CTG baseline is 150. The variability is low. Okay, there is no acceleration. There are variable deceleration. How many amber features? 2 amber features, right? Variable deceleration, low variability. So this is a pathological CTG. Okay, but what should be done? Can we go for cut 1? No. Can we go for fetal blood sampling? No. Can we require continuous obstetric view? I can go for it, but they are saying that this is a suspicious CTG. This is not correct. Okay, the correct answer is that this is a pathological CTG and we should try to correct the underlying cause or try conservative measures. And in this case, we can also consider fetal scalp stimulation because it's pathological. If it does not improve, we are going for CAT2CS. Okay, what about this one? This is also a pessary. Okay, 20 minutes later, the pessary is removed. Okay, here it's very obvious, thank God. So let's count, okay? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Every big square is 1 minute. So from here to here, we have 10 minutes. Can you see any hyperstimulation? No. Okay. The baby, what about the baby? The baseline for the baby here is 120. Okay, here is 130. So I can say that the baseline is about 130, approximately. If you're going to consider this as a deceleration, so it's one, only one. Okay, I wouldn't say this is a deceleration. This is okay. So I think it's okay. Even here, the peak is with the peak, right? Here we have the start of the deceleration is with the peak of the contraction. I wouldn't say that this is a deceleration because the baseline actually, to be specific, is not really here. The baseline should got every contraction. So it's like here. Exactly. Okay. So anyway, are you going to go for CS? If there is any acute hypoxia? No. Okay. Are you going to give terbutaline? No. Are you going to do a fetal blood sampling? It's obsolete now. So reassure and observe. Okay. What about this one? I need you to tell me if there is any amber feature. Yes, excellent. The variability is less than 5 beats per minute. Okay, so we have only one amber feature. So is this a suspicious or pathological CTG? Suspicious, excellent. Because they might ask me about the category of this CTG, right? Right, okay. So this is a suspicious one. So what should I do? Let's see from the scenario. Can I correct any underlying cause? Is there any underlying cause? Yes, the oxytocin. If she is on oxytocin or dinoprostone or any induction, I'm going to stop it. Then I'm going to think about other measures. Yes, excellent. Okay. before we go on, we had reviewed all CTGs that came before. Do you want to ask about anything? Yeah, someone asked about this CTG. Okay, you have a doubt. You have a doubt that this is a deceleration or not. Okay? Deceleration, in definition, mean that you are going to decline from the baseline more than 15 beats per minute for more than 15 seconds, quarter of a minute. Okay? So let's see. Let's see if we agreed. If we agreed that average, we are talking about I can see it says 90, I think, 100, 120. This is 140. Okay, so the baseline is approximately 140. Okay, so I'm having a decline here. Okay, this is a deceleration for 15 or more. Yeah, okay, 15 or more, but for how long? For how long? It's not sustained for 15 seconds. Hey guys, deceleration are very apparent, like this one. For example, like this one. It would be like this, but a little deeper. It would be like this, but a little deeper. Because I'm talking about 15 seconds. 15 seconds means quarter of a minute. So at least it would be from here to here. Okay, but deep. Not like this. Like this one, this is not deceleration. This one, this is not deceleration. This is a variability. Okay, if we doubt that from here to here, this is a deceleration, for example, and there is a variability inside the deceleration. Okay, I would go with this. Let's see where it starts. It starts with the start of the contraction. The peak is more or less with the peak of the contraction, and it starts to gain back after the contraction stop. This is early deceleration. Okay, this is early deceleration, so it's totally normal. Okay, so let's start now some obstetric cases.